Rheumatoid arthritis. Rheumatoid arthritis, RA, is a symmetric, inflammatory, peripheral polyarthritis of unknown etiology. It typically leads to deformity through the stretching of tendons and ligaments and destruction of joints through the erosion of cartilage and bone. If it is untreated or unresponsive to therapy, inflammation and joint destruction lead to loss of physical function, inability to carry out daily tasks of living, and difficulties in maintaining employment. The annual incidence of rheumatoid arthritis is approximately 40 per 100,000, and the prevalence is about 1% in Caucasians but differs in other populations. Women are affected 2 to 3 times more often than men. RA can occur in patients at any age, and the peak onset is between the ages of 50 and 75. Etiology. Gender-specific factors. Gender-specific factors affect susceptibility to RA in ways that remain incompletely understood. Genetic risk factors. Substantial data have emerged about the importance of genetic risk factors for RA from studies of twins and siblings, human leukocyte antigen, HLA, and non-HLA susceptibility genes, and other polymorphisms. The firmest link between a genetic susceptibility factor and RA is the association of the disease with an epitope in the third hypervariable region of the HLA-DR beta chains, known as the shared epitope. Smoking. Cigarette smoking is a strong risk factor for the development of RA, particularly in individuals with the shared epitope. Infection. A role for viral or bacterial C as an inciting trigger for RA has been hypothesized, but no single agent has been proven responsible. Obesity. Obesity is associated with increased risk of RA, while mild to moderate alcohol use may reduce risk. Other factors. Various occupational and other exposures as well as environmental and other factors have been associated with modifying the risk for the pathology. A synovitis, synovial cell hyperplasia, hypertrophy with CD4 lymphocytic infiltration and synovial effusion, B. pannus formation. Cartilage lost. Fibrosis. Bony erosion, deformity, fibrous and bony ankylosis. Muscle wasting. Periarticular osteoporosis. Rheumatoid nodules. Characteristic histologic changes in nodules showing granulomatous foci with central zones of cell necrosis, surrounded by a palisade of proliferated mononuclear and peripheral fibrosis and chronic inflammatory cell infiltration. Clinical features. The onset of RA is frequently heralded by prodromal symptoms such as fatigue, anorexia, weight loss, weakness, and generalized aching and stiffness. Joint disease. The small joints of the hands, the wrists, knees, and feet are most commonly involved. It usually is bilateral, symmetrical, and polyarticular. Common symptoms are morning stiffness, swelling, typical hand deformities, limited joint motion, extra-articular manifestations, rheumatoid nodules, pleuropulmonary manifestations, cardiac manifestations, neuropathy, Sjogren's syndrome, ocular manifestations, ear manifestations, skin manifestations, gastrointestinal manifestations, bone manifestations. Others. Nonarticular manifestations of rheumatoid arthritis. Respiratory system. Pleurisy with or without effusion. Pneumothorax. Rheumatoid nodule, Kaplan's. Interstitial fibrosis. Pneumonia. Chronic bronchitis or bronchiectasis. 7. Pulmonary hypertension. Cardiovascular system. Pericarditis. Endocarditis. Cardiomyopathy. Conduction defects. Cardiac arrhythmias. Infiltration of valves, mitral incompetence and aortic Incompetence. Myocardial infarction, due to coronary vasculitis. Gastrointestinal system. Xerostomia. Parotid enlargement. Dysphagia. Mesenteric artery occlusion. Renal system. Pyelonephritis. Analgesic nephropathy. Amyloidosis. Lymph nodes. Local and generalized lymphadenopathy. Ocular. Episcleritis, scleritis. Keratoconjunctivitis sicca. Scleromalacia perforans. Ear. Defective hearing, involvement of ossicular chain. Muscle. Weakness and atrophy. Myopathy, steroid, chloroquine. Tenosynovitis. Skin. Dermal atrophy. Leg ulcers. Nail dystrophy. Nodules. Pyoderma gangrenosum. Bones. Periarticular osteoporosis. Central nervous system. Cervical dislocation, quadriplegia. Peripheral neuropathy, sensory and motor. Autonomic neuropathy, reduced sweating, cold hands, and palmar erythema. Entrapment neuropathy. Hematological. Anemia. Hemolytic anemia. Serum iron low. Iron binding capacity normal. Raised ESR. Neutropenia, pancytopenia, and splenomegaly, Felty syndrome. Eosinophilia, vasculitis, nodules. Hyperviscosity syndrome. It is due to increased rheumatoid factor. The manifestations are dizziness, diplopia, dyspnoea, and bleeding tendency. Vasculitis complications including dermal infarction, cerebrovascular accidents, myocardial infarction, gut gangrene, digital gangrene, and neuropathy. Variants of rheumatoid arthritis. Felty syndrome. It is characterized by splenomegaly, neutropenia, pancytopenia, and lymphadenopathy. Still's disease. Rheumatoid arthritis occurring in children. It is characterized by mono or polyarthritis, fever, maculopapular rash, hepatosplenomegaly, lymphadenopathy, and leukocytosis. The rheumatoid factor and anti-nuclear antibody are negative. It mostly occurs in juvenile age group. The joint deformity is rare but growth retardation is present. Sjogren's syndrome. It is characterized by enlargement of lacrimal and salivary glands, xerostomia, keratoconjunctivitis sicca, leukopenia, lymphocytosis, and eosinophilia. The rheumatoid factor is positive and there is eosinophilia. Investigations. Complete blood count, anemia, thrombocytosis, increased ESR. Increased acute phase proteins, C-reactive protein. Increased plasma viscosity. Serum proteins, decreased albumin, increased gamma globulins, increased alpha-2 globulin and increased IgG, IgM, IgA. Serological tests. Rheumatoid factor. Rheumatoid factors are immunoglobulins of the IgG or IgM class which react with the Fc portion of IgG. It is produced by plasma cells and lymphocytes in subsynovial tissue and draining lymph nodes. It is detected by a Rose-Waller test. It is more specific and is said to be positive when more than 132. B latex test. It is sensitive, but less specific and said to be positive when more than 120. The above two tests are used to detect IgM rheumatoid factor. Radiological features of rheumatoid arthritis. Early signs are soft tissue swelling, periarticular osteoporosis, periosteitis. Erosions, periarticular and subarticular cysts. Late signs are narrowed joint spaces, articular surface irregularity, osteoporosis, subluxation, ankylosis and secondary osteoarthritis. Anti-nuclear antibody is positive in 20 to 50%. LE cell is positive in 10 to 20%. Pleural fluid analysis, low glucose, increased LDH, and low complement. Synovial fluid analysis. Antibodies to CCP, cyclic citrullinated polypeptide. This test has similar sensitivity and better specificity for RA than RF. Presence of anti-CCP is most common in person with aggressive disease with a tendency for developing bone erosion. Criteria for the diagnosis. 1. Morning stiffness, more than 1 hour for more than 6 weeks. 2. Arthritis involving 3 or more joint areas, with or without soft tissue involvement lasting more than 6 weeks. 3. Arthritis of hand joints, wrist, MCP, or PIP joints more than 6 weeks. 4. Symmetrical arthritis, at least one area lasting for 6 weeks. 5. Rheumatoid nodules. 6. Rheumatoid factor. 7. Radiographic changes. Diagnosis of rheumatoid arthritis is made when 4 or more criteria are present. Management. A. Goals. 1. Education and motivation. 2. Disease modification through the suppression of inflammation and the immunologic process which is active systemically and in the joints and other tissues. 3. Maintenance of joint function and prevention of deformities. 4. Repair of joint damage if it will relieve pain or facilitate function. B. Systemic and articular rest. 1. Short bed rest is recommended for about an hour in the mid-morning and mid-afternoon. 2. Splints. The wrist splints are particularly useful during bouts of acute wrist synovitis and for management of carpal tunnel syndrome. C. Physiotherapy. 1. Regular exercise. Exercise is most successful after heat application. A 15-minute early morning shower or a bath at 98-100 F will help decrease morning stiffness. Static quadriceps exercises should be performed to strengthen the muscular, ligamentous, and tendinous support of the knees. 2. Joint protection. The principles of joint protection are maintenance of muscle strength and range of motion, avoidance of positions of deformity, the use of the strongest joints possible for a given task, and the utilization of joints in the most stable anatomic planes. D. Drug therapy. Group 1, nonsteroidal anti-inflammatory drugs, NSAIDs. A. Aspirin. B. Indomethacin. C. Phenamides. D. Propionic acid compounds. E. Sulindac, Clinaril. F. Tolmedin. G. Piroxicam. H. Diclofenac. ICOX2 inhibitors. Choice of NSAIDs. The general approach is to choose an NSAID and treat for 2-4 weeks, the usual time period needed to define the drug's efficacy and side effect profile. Group 2, disease-modifying agents, DMARDs. Gold. Penicillamine. Chloroquine. Sulfasalazine. This group of drugs take a long time, 6 to 12 weeks, for their actions to commence, and so in the induction phase, NSAIDs must be given to reduce pain and their dose should be tapered subsequently. Indications. Failure of conservative management, even after 3 months with NSAIDs and general measures, and rapidly progressive erosive arthritis. Group 3, highly toxic drugs. Corticosteroids and ACTH. Flunamide. Azathioprine. Cyclophosphamide. Cyclosporin. Levamisole. ACTH is preferable in children since it does not interfere with growth. The drug of choice is prednisolone. Group 4, cytokine antagonist. Tumor necrosis factor TNF-alpha antagonist. Anti-TNF-alpha drugs produce a very good response when combined with methotrexate. 1. Infliximab, it is a chimeric monoclonal antibody that binds with high affinity and specificity to human TNF-alpha. 2. Etanercept, it is a recombinant fusion protein capable of binding to two TNF-alpha molecules. It has an earlier onset of action than methotrexate. 3. Adalimumab, it is a fully human monoclonal antibody against TNF-alpha. Interleukin-1 receptor antagonist. Anakinra, it is a recombinant form of naturally occurring interleukin-1 receptor antagonist that is approved for use in RA. Plasmapheresis, it is an impractical long-term therapy and its short-term use remains controversial. A novel approach, pheresis across a column bound with staphylococcal protein A, the prosorbicolumn, has been approved for the treatment of RA. Medical synovectomy, yttrium-90 silicate is used for larger joints and erbium-159 acetate for smaller joints. Joints should be immobilized for 72 hours to prevent the spread to adjacent lymph nodes. It is contraindicated in patients below 45 years. Surgical synovectomy, arthroplasty, osteotomy, arthritis. Poor prognostic factors: increased duration of morning stiffness, high titer of rheumatoid factor, increased ESR, mode of onset, insidious onset of disease, weak hand grip, increased feet walking time, systemic involvement active more than 1 year, without remission, associated vasculitis, rheumatoid nodules, involvement of cervical joints, protracted anemia. Thank you.